Welcome back to Beyond the Stethoscope, the podcast for general practitioners.
Great to be here.
For all you dedicated GPs and our GP registrars getting ready for those fellowship exams, we've got another deep dive for you.
That's right.
If you find this useful, please do give us a like, subscribe so you don't miss future ones, and share it around with colleagues. Let's all learn together.
Absolutely. And today we're tackling, well, a really core topic, something you'll definitely see in practice and definitely high yield for the exams, jaundice.
Right.
We're basing this on Chapter 47 of John Murtaugh's General Practice, the 8th edition. The aim today is to really unpack it, not just the definition, but the why, the mechanisms, the diagnostics, the management, stuff relevant for your day-to-day.
Okay, sounds good. So jaundice, that classic yellow skin, yellow eyes. The chapter starts with the basics, but let's just refresh everyone on what's actually going on there, physiologically speaking.
Sure. So at its heart, jaundice is just the visible sign of too much bilirubin in the blood. Serum bilirubin. The chapter mentions the diagnostic threshold is over 19 noyulet, but you probably won't actually see it, the clinical yellowing, until it gets above 50 noyulet.
50, yeah.
And even then, a little practical point, if the lighting's poor, it can be surprisingly difficult to spot visually if the level's below, say, 85 moilets.
Good tip. And we sometimes see patients who look a bit yellow, but maybe it's not jaundice. How do we quickly sort that out? Is it the carrots thing?
Exactly. That's the classic differential. Hyperkeratinemia from, well, too many carrots or beta-carotene supplements, or even sometimes hypothyroidism.
Okay.
The absolute key is the sclera, the whites of the eyes. In true jaundice, bilirubin stains them yellow too. With the other things, hyperkeratinemia or hypothyroidism, the skin might look yellowish, but the sclera stay white.
Sclera are key. Got it. It's interesting the chapter even mentions Hippocrates recognizing something similar way back when.
Yeah, it's amazing, isn't it? He described this disease, maybe hepatitis, linked to the liver, causing pain and a changed complexion. Shows how long we've been observing these signs, even if the understanding has evolved a bit.
Definitely. Okay, so we've confirmed it as jaundice, sclera, or yellow. For us GPs, what are the main categories, the big buckets of causes we should be thinking about?
Murtaugh's lays it out quite nicely into 3 main types. You can almost picture it as a pathway.
Okay.
First, there's obstructive jaundice. That's where bile flow is blocked, either outside the liver, extrahepatic, or actually within the liver, intrahepatic.
Right, a blockage.
Then there's hepatocellular jaundice. That means the problem is with the liver cells themselves. They aren't working properly.
Okay, the cells are sick.
And third, hemolytic jaundice. This comes from red blood cells breaking down too quickly, hemolysis, which just overwhelms the liver's ability to process all the bilirubin produced.
Obstructive, hepatocellular, hemolytic. Got it. So patient walks into the clinic, they're jaundiced. What are the odds? What are the most common things we're likely dealing with?
In general practice, Murtaugh's lists the most frequent causes, sort of in order, as viral hepatitis, then gallstones, pancreatic cancer, cirrhosis, pancreatitis, and finally, drugs.
That's quite a mix. Infections, structural problems, chronic disease, medications.
Exactly. It really highlights why you need such a thorough history. The chapter stresses this. You've got to ask about recent travel, all drugs, including over-the-counters and herbals, alcohol, any contact with hepatitis. It's crucial.
Absolutely. Okay, so we have a jaundiced adult in front of us. How do we structure our thinking? The chapter offers a diagnostic strategy model, right?
It does, and it's really useful. It breaks it down into, well, probability diagnoses, what's most likely, then serious disorders, not to be missed, the red flags, and finally, pitfalls, the things we might easily overlook.
Okay, let's start with probability. What's usually top of the list?
Think about those common causes we just mentioned. Hepatitis A, B, C, remembering B and C are often more chronic. Gallstones causing a blockage in the common bile duct, and alcoholic liver disease, whether it's acute hepatitis or underlying cirrhosis. And things like the patient's age, their social situation, any risk behaviors, travel history, all that really shifts the probabilities.
Makes sense. Now, what about those serious conditions, the ones we absolutely cannot afford to miss?
This is where you need that high index of suspicion. Malignancy is always a worry. Cancers of the pancreas, the biliary tract, the liver itself, hepatocellular carcinoma or metastases spreading to the liver, especially in older patients, or someone with known chronic Hep B or C.
Okay, malignancy. What else?
Severe infections. Think septicemia or ascending cholangitis, that's infection climbing up the bile ducts. Remember Charcot's triad?
Right, upper quadrant pain, fever chills, and jaundice.
Exactly. That's a major surgical emergency usually.
Yeah.
Also, fulminant hepatitis, rapid, severe liver failure. And HIV/AIDS can present with liver issues too.
Okay, serious infections. Any rarer serious things?
Yes, things like Wilson disease. Especially think of it in younger people with acute hepatitis, maybe some neurological signs like tremor or a family history. Need to check ceruloplasmin, maybe slit lamp for Kaiser-Fleischer rings, potentially biopsy.
Yes. Right.
Ray syndrome too, thankfully rare now, but classically in kids after a viral illness, especially if aspirin was used, causes rapid liver and brain problems. And in pregnancy, acute fatty liver of pregnancy is a life-threatening emergency presenting with jaundice. Needs urgent attention.
Wow, quite a list of must-not misses.
Hmm.
What about the pitfalls? The things that are maybe less dramatic but easily overlooked?
Gallstones again, actually,
Expand.
particularly in older people where they might present without that classic severe pain, just jaundice.
Painless gallstones.
Yeah, and Gilbert syndrome, super common cause of mild unconjugated hyperbilirubinemia. Benign, but you need to recognize it so you don't over-investigate.
Right. Good.
Heart failure, surprisingly. Sometimes it presents with jaundice and right upper quadrant tenderness from liver congestion. LFTs can be variable. Worth considering if the picture fits.
Cardiac jaundice, okay.
Then there are rare inherited conditions like Dubin-Johnson or Rotor syndromes causing conjugated hyperbilirubinemia. Hemochromatosis, look for skin pigmentation, maybe diabetes. Chronic active hepatitis, primary biliary cirrhosis, PBC, often very itchy. Primary sclerosing cholangitis, PSC, think ulcerative colitis association. And chronic viral hepatitis that's just been simmering away unnoticed.
So many possibilities.
Don't forget other infections like CMV, EBV, leptospirosis, and of course, drugs, again, easy to miss if you don't ask specifically.
The chapter also points out some general pitfalls in just assessing the patient, doesn't it? Like lighting.
Yes, absolutely. Trying to assess scleral color in artificial light. Very difficult, can mislead you. Also be aware older patients' sclera can sometimes look a bit yellow normally.
Right.
And it stresses, really stresses, getting a full drug history, explicitly asking about illicit drugs, don't assume.
Crucial.
And finally, not delaying referral for biopsy if you suspect chronic hepatitis. It's often needed for proper diagnosis and staging.
It also mentions a 7 masquerades checklist relating to jaundice. What's that highlighting?
For jaundice specifically, it flags hemolytic anemias and drugs as key masquerades. Things that present with jaundice but aren't primarily liver or biliary disease, so they need a different diagnostic track.
Okay, let's really focus on drug-related jaundice then, because the chapter says it's common. What should make us suspect it?
Well, first off, just remember that loads of drugs can potentially cause liver injury in jaundice. It's called DILA, drug-induced liver injury.
Right.
The pattern of injury can vary. Some drugs cause cholestasis, blocking bile flow. Others cause direct liver cell death, necrosis, which glomas, some chronic active hepatitis, even cirrhosis long-term, rarely tumors. Or veno-occlusive disease affecting liver veins.
The different mechanisms.
Yeah, and don't forget some drugs, like methyl-dopa was the classic example, can actually cause hemolysis, leading to that pre-hepatic type of jaundice.
Okay, the chapter has a huge table of drugs. It's a bit daunting.
Yep.
Any key takeaways for us busy GPs?
It is extensive, but maybe think in categories. For hemolysis, methyl-dopa is the one to remember. For direct hepatocellular damage, think dose-dependent versus dose-independent.
Dose-dependent like paracetamol.
Exactly. Paracetamol overdose is the classic. Salicylates, tetracycline too, that highlights dosage importance. But the dose-independent ones are trickier, unpredictable.
Like what?
Oh, loads. Anesthetics like halothane, antidepressants, MAOIs, duloxetine, antiepileptics, phenytoin, valproate, carbamazepine, many antibiotics, penicillins, sulfonamides, antimalarials like Fansidar, antiretrovirals, TB drugs like isoniazid, NSAIDs, heart drugs like amiodarone, methyl-dopa again, statins like simvastatin. A huge list.
Wow. Really underscores needing that detailed med history.
Absolutely. And that's just the hepatocellular damage list.
Okay, what about drugs causing cholestasis, that bile blockage pattern?
Key ones mentioned are antithyroid drugs, chlorpromazine, erythromycin estilate specifically, penicillins, especially flucloxacillin, that's a notorious one for cholestasis,
Flucloxacin, right?
gold salts, oral contraceptives, estrogens, anabolic steroids, older diabetes drugs like chlorpropamide, even amitriptyline.
Okay.
And then there's a kind of other group things like allopurinol, cimetidine, DMARDs like methotrexate, azathioprine, immunomodulators, nitrofurantoin, illicit drugs like ecstasy or cocaine, even high-dose vitamin A, and various complementary medicines. Basically suspect everything.
Assume any drug could be guilty until proven innocent.
No.
Okay. Let's switch gears to hemolysis causing jaundice. How does that usually look?
Patients often have symptoms of the anemia itself, fatigue, maybe breathlessness, looking pale alongside the jaundice.
Makes sense.
And typically you don't get the really dark urine or pale stools you see with obstruction because it's mostly unconjugated bilirubin that hasn't gone through the bile ducts yet.
Oh, okay.
The jaundice itself can range from just a slight lemon yellow tint, sometimes seen in pernicious anemia, to really deep jaundice in a severe hemolytic crisis.
And the causes?
Can be inherited, think hereditary spherocytosis, thalassemia, major, or acquired maybe an incompatible blood transfusion. Certain cancers like lymphoma, severe infections, sepsis can trigger it, and as we said, some drugs.
And physically, anything to look for?
Splenomegaly, an enlarged spleen, is a common finding in many hemolytic conditions. Always worth checking for.
Right, check the spleen. Okay, so given this huge range of causes, that history taking seems absolutely vital. What are the must-ask questions for a jaundiced patient?
Robertas gives a great checklist you need to ask.
I don't
Any
know.
previous jaundice, for them or family, changes in stool or urine color, appetite loss, sore throat, weight loss, itching pruritus, abdominal pain.
Okay, the basics.
Then dig deeper. Where do they live? Who with?
Okay.
Any contact with known hepatitis or jaundice cases? Recent travel? Any blood exposure, needles, tattoos, acupuncture, IV drug use?
Right, risk factors.
Diet, especially shellfish, dodgy water. Sexual history, full drug history, prescription, OTC, recreational, alcohol, paracetamol. Recent surgery or medical procedures. Family history of jaundice, hemolytic disease, genetic liver stuff. Ethnic background relevant for some hemolytic conditions or Hep B risk. Occupation? Any hazards.
That's comprehensive.
Yeah.
Are there patterns in the symptoms that might point us in a certain direction?
Yes, definitely. For example, pain in the right upper quadrant makes you think gallstones, acute hepatitis, maybe cholecystitis.
Okay.
Anorexia, dark urine, fever together strongly suggests viral hepatitis, though alcoholic or drug hepatitis are possible too.
Itching.
Pruritus strongly suggests cholestasis, that bile flow blockage, but it can occur in other liver diseases too.
And joint pain or rash.
That might point towards viral hepatitis or maybe an autoimmune hepatitis picture.
Okay, great history done. Now, the examination. What are the key physical signs we're looking for?
Abdominal exam is critical. Palpate the liver size, consistency, smooth, nodular, firm, tenderness. Feel for the gallbladder, is it palpable? And the spleen enlarged. Check for ascites, that fluid in the belly.
What does a palpable gallbladder mean?
Usually suggests extrahepatic obstruction, often malignancy, that's Courvoisier's law again. An enlarged spleen points more towards hemolysis, portal hypertension from chronic liver disease, or maybe viral infections.
Got it. What else beyond the abdomen?
Look for signs of chronic liver disease, scratch marks from itching, red palms, palmar erythema, easy bruising, spider naivety on the skin, muscle wasting, testicular atrophy in men, gynecomastia.
Stigmata of chronic liver disease.
Exactly. Also test for asterixis, that liver flap. Check their breath for Phaeater hepaticus, that sweet, musty smell of liver failure. And feel for lymph nodes, could indicate malignancy or infection.
And the urine dipstick.
Simple but useful. Check for bilirubin, shouldn't be there normally, and urobilinogen.
Right. Okay, history and exam done. Time for investigations. Blood test first. Where do we start?
Usually a full blood examination, FBE, looking for anemia, signs of hemolysis, and liver function tests, LFTs, plus standard viral serology for hepatitis A, B, and C, maybe EBV, CMV, depending on the picture.
And fractionating the bilirubin.
Yes, definitely ask for conjugated versus unconjugated. Really helpful. High unconjugated suggests hemolysis or maybe Gilbert's. High conjugated points more to hepatocellular or obstructive causes.
The chapter details typical LFT patterns. Can you quickly summarize those?
Sure, hepatocellular pattern like viral hepatitis. ALT and AST are usually very high, much
Yeah.
more so than ALP and bilirubin.
Okay, enzymes way up.
Hemolytic jaundice,
Hmm.
mostly high unconjugated bilirubin. Other LFTs often normal or only slightly up.
Bilirubin up, enzymes okay.
Obstruction. ALP and GGT tend to be significantly elevated, along with the bilirubin. A STALT might be up a bit too, but the ALP-GGT rise is often more prominent.
ALP-GDT prominent.
Got it. Gilbert syndrome, just isolated unconjugated hyperbilirubinemia, usually mild, less than 50.
Isolated bilirubin rise.
Liver mets, or abscess, can mimic obstruction. Sometimes a very high ALP is the main clue.
High ALP.
Alcoholic liver disease. Often see AST higher than ALT, maybe a 2.1 ratio or more. GGT usually raised too.
AST-ALT ratio, useful pattern, and the specific viral markers.
For Hep A, IgM anti-HAV means recent infection. For Hep B, HBsAg, the surface antigen, is the main screen for current infection. For Hep C, we usually start with the anti-HCV antibody test.
Okay. Beyond bloods, imaging is key. How do we choose which scan?
Ultrasound is usually the first step for jaundice. It's great for gallstones, checking bile duct size, looking for liver masses, fatty liver.
So start with ultrasound.
Generally, yes. A plain X-ray might show some gallstones if they're calcified, but less useful overall. A hepatitis scan is more specific for gallbladder function, good for suspected acute cholecystitis.
And if ultrasound isn't clear?
Then CT scan is often next, especially if you're worried about the pancreas or deeper structures. MRCT, that's magnetoresonance cholangiopancreatography, gives excellent non-invasive pictures of the bile ducts, often used before potentially doing an ERCP.
What about ERCP and PTC?
ERCP, endoscopic, and PTC, percutaneous, are more invasive but give detailed bile duct images and allow interventions like removing stones or placing stents. ERCP goes via the mouth, PTC through the skin into the liver.
Okay. Any other imaging?
Liver isotopic scans are less common now but can show cirrhosis patterns. And FibroScan, that's a type of ultrasound measuring liver stiffness, is great for assessing fibrosis non-invasively.
Right, FibroScan for fibrosis. The chapter also lists more specialized blood tests. When would we use those?
Yeah, it depends what you suspect. Autoantibodies, ANA, SMA, AMA if you're thinking autoimmune hepatitis or PBC, CEA, tumor marker for suspected colorectal mets, iron studies for hemochromatosis, alpha-fetoprotein, AFP, for hepatocellular cancer risk, serum ceruloplasmin for Wilson disease.
Specific tests for specific suspicions.
Exactly. And if initial viral screens are negative that you still suspect a virus, you might check EBV-CMV serology. Ultimately, liver biopsy might still be needed for a definitive diagnosis in complex cases.
Okay, let's shift focus to specific patient groups. Jaundice in children, big topic.
Huge. Especially neonatal jaundice, super common. The absolute first step is it conjugated or unconjugated bilirubin?
Why is that so critical?
Because conjugated hyperbilirubinemia in a newborn is always pathological. Always. Needs urgent referral to look for serious things like biliary atresia, bile duct cysts, neonatal hepatitis.
Okay, conjugated bad, urgent referral.
And jaundice appearing in the first 24 hours of life is also always pathological, usually hemolysis from blood group incompatibility, ABO, or rhesus disease.
Rhesus disease.
Yeah.
We screen for that antenatally.
Yes, and prevention with anti-D immunoglobulin is key. Severe rhesus disease can cause high drops, anemia, mater jaundice, big liver, and spleen. Table 47.5 in Murtaugh's lists the key causes of pathological neonatal jaundice all need pediatric input.
And the risk is connectorous.
Exactly. Bilirubin encephalopathy from very high unconjugated bilirubin. That's why we have treatment thresholds using phototherapy or even exchange transfusion.
What about physiological jaundice?
That's a diagnosis of exclusion. Mild, unconjugated, peaks day 3-5, baby is otherwise well. Might still need phototherapy if levels get too high.
And ABO incompatibility.
Typically, mom is blood group O, baby is A or B. Jaundice, often within 24 hours, positive Coombs test, needs prompt phototherapy, careful follow-up.
Breast milk jaundice.
That's later onset, usually after the first week. Unconjugated, healthy baby, often resolves if you temporarily stop breastfeeding for a day or two.
And older kids.
Viral infections are the most common cause then, especially Hep A or B. Chronic viral hepatitis is much less common in childhood.
Okay. Now, what about jaundice in the elderly? Different patterns there.
Yes, obstructive jaundice becomes more common. Often gallstones, remember, they can be painless in the elderly. Or malignancy pancreas, biliary tract, stomach cancer, METs.
Courvoisier's law again.
Right. Painless jaundice plus a palpable gallbladder strongly suggests malignancy. Alcoholic liver disease can also present for the first time, and cirrhosis from alcohol is a common cause of hepatocellular jaundice in older adults.
Drugs still a factor.
Definitely. Polypharmacy is common, so always consider drug-induced liver injury. Careful drug history is vital. Hepatitis A is actually less common in this age group compared to younger people.
Interesting. Let's dive into the infective causes now, the hepatitis viruses. The chapter covers them in detail.
It does. Hepatitis A, fecal-oral spread, usually contaminated food or water. Less common now in developed countries. Importantly, no chronic state, no carrier state, often mild or subclinical. Diagnosis is IgM, anti-HAV. Management is supportive, focus on hygiene. Vaccine available.
Okay, Hep A is acute, self-limiting usually. Hep B.
Transmitted by blood, sex, perinatal, close contact. Most acute infections are actually subclinical, but a percentage, especially if infected young, become chronic carriers. Risk of chronic hepatitis, cirrhosis, liver cancer long-term.
Complex serology for Hep B, right?
Yes, HBsAg for current infection. HBsAg often means high infectivity. Various antibodies tell you about past infection, immunity, etc. Effective vaccines, both passive HBsAg and active, are crucial.
Clinical picture of acute Hep B.
Can be like Hep A, maybe less abrupt onset. Can have that serum sickness-like thing with rash and joint pain initially. Chronic Hep B is HBsAg positive for 6 months. Management involves monitoring, sometimes antiviral treatment, P. interferon, and entecavir, tenofovir to suppress the virus. Prevention via vaccination and HBsAg in specific cases like newborns of positive mothers is key.
And hepatitis C.
Now, the most common chronic viral hepatitis here in Australia, mainly IV drug use, tattooing, less common via sex or perinatal routes, acute infection often very mild or asymptomatic, often picked up on routine LFTs.
And it often becomes chronic.
Yes, a high percentage develop chronic infection, which can lead to cirrhosis and liver cancer over decades. Figure 47.7 shows that progression. Fibroskin helps assess fibrosis. Diagnosis is anti-HCV antibody, then HCV RNA, PCR, to confirm active virus.
Treatment for Hep C has changed dramatically, hasn't it?
Revolutionized. Direct-acting antivirals, DAAs. Cure rates over 90%. Treatment is based on genotype. Examples include protease inhibitors, polymerase inhibitors, NS5A inhibitors, often managed in GP setting with specialist collaboration now. Pre-treatment assessment is important.
Curvians.
Undetectable HCV RNA 12 weeks after finishing treatment. Need to watch for Hep B reactivation if co-infected, though.
Okay, what about Hep D, E, F, G?
Hep D needs Hep B to replicate. Parenteral spread often leads to severe chronic disease. Hep E is enteric, like Hep A, can be severe, especially in pregnancy. F and G are rarer, less well understood.
The chapter also mentions other infections causing jaundice.
Yeah, as part of a systemic illness, malaria, EBV, motto, CMV, Q fever, toxo, syphilis, lepto, even measles, varicella, yellow fever sometimes.
Right, and markers suggesting cirrhosis in someone with hepatitis.
Things like increased INR, low platelets, thrombocytopenia, low albumin, and a NASTALT ratio greater than 1 can suggest underlying cirrhosis.
Okay, let's go back to cholestatic jaundice, impaired bile flow. Key causes.
Can be intrahepatic, problem inside liver, or extrahepatic, blockage in large ducts. Table 47.8 lists them. Think gallstones in the common bile duct can cause pain, fluctuating jaundice, fever, cholangitis. Ultrasound and ERCP are key investigations.
What about inflammation without stones?
A calculus, cholecystitis, gallbladder inflammation without stones can be acute, often in very unwell patients like diabetics or chronic.
And acute cholangitis.
That's the bacterial infection of bile ducts, usually due to obstruction like a stone. Charcot's triad we mentioned. Urgent referral needed.
Pancreatic cancer.
Carcinoma of the head of pancreas often presents with painless, progressive, obstructive jaundice, maybe that palpable gallbladder, weight loss, back pain. Ultrasound CT, then ERCP. Prognosis often poor.
Yeah,
Jaundice is usually a late sign in most types of cirrhosis, except PBC maybe, indicating poor liver function. Often see ascites, encephalopathy, etc., figure 47.9, caused by alcohol, chronic viral hepatitis mainly, but other causes too.
Autoimmune condition.
Autoimmune chronic active hepatitis, ACAH, often young women, insidious onset, need specific antibodies, biopsy. Treated with steroids, immunosuppressants, primary sclerosing cholangitis, PSC, inflammation of bile ducts associated with ulcerative colitis, progressive jaundice, itching, primary biliary cirrhosis, PBC, uncommon, chronic, mainly women itching, obstructive LFTs. Treated with ursodeoxycholic acid.
Alcoholic liver disease.
Spectrum. Fatty liver, alcoholic hepatitis can lead to cirrhosis and established cirrhosis. Stopping alcohol is paramount.
Fatty liver.
Hepatic steatosis, very common, due to alcohol, obesity, diabetes, high triglycerides, steroids, often asymptomatic. Weight loss helps if related to obesity and metabolic factors.
And hemochromatosis.
Iron overload, discussed more in Chapter 23, can cause cirrhosis.
Okay, nearly there. Special patient groups, again, return travelers.
Think Hep AE, malaria, cholangitis, drug reactions, antimalarials like mefloquine. Chapter 129 covers this.
Jaundice in pregnancy.
Important causes: intrahepatic cholestasis of pregnancy, acute fatty liver of pregnancy, emergency, severe preeclampsia LLP syndrome. Often needs delivery around 37-38 weeks.
Post-op jaundice.
Many causes. Effects of surgery, anesthesia, hypoxia, drugs, transfusions, hepatitis, hemolysis, sepsis, uncovering underlying liver disease, cholestasis after major surgery.
Neonates of HB egg positive mothers.
Need Hep B immunoglobulin, HBIg, and the first vaccine dose within 24 hours of birth. Then complete the vaccine course. Crucial for preventing vertical transmission.
Okay, bottom line, when do we absolutely need to refer a jaundiced patient?
Definitely refer if you suspect fulminant hepatitis. Anyone with chronic liver disease or cirrhosis, painless obstructive jaundice, high suspicion of malignancy, any evidence of malignancy, symptomatic gallstones needing intervention, acute fatty liver of pregnancy urgent, and suspected rare conditions like Wilson's.
Great summary. Finally, any key practice tips from the chapter to leave us with?
Suspect all drugs. Remember, Hep A IgM is recent, IgG is past immune, no chronic Hep AE. Test all jaundiced patients for HBsAg. Hep B carriers, persistent HBsAg, need monitoring. HBAg means higher infectivity. Raised GGT plus raised MCV is a good screen for alcohol excess. Listen over the liver, a systolic murmur can occur in alcoholic hepatitis or hepatoma. Distaste for smoking can suggest acute viral hepatitis. And sadly, ascites usually means a poor prognosis in liver disease.
Fantastic. That was incredibly thorough, really pulling out the key points from Murtaugh's Chapter 47 for GPs and registrars. It's complex, but that structured approach is so helpful.
Exactly. History, exam, targeted investigations, knowing the patterns, the red flags, and when to refer, that's the core of managing jaundice safely and effectively in general practice.
We really hope you found that useful. Do revisit the material, look at the chapter, and think how it applies day to day. Let us know your thoughts or questions on social media.
Yeah, keep learning, keep questioning. It's how we provide the best care.
Thanks so much for tuning in to Beyond the Stethoscope, the podcast for general practitioners. Please do like, subscribe, and share. We'll see you next time for another deep dive.